but even that feels rushed and inadequate. And there's just a lot that's been written in this space, a lot that is still misunderstood, and we're still trying to figure out. So I apologize in advance because this may feel not very deep. The one thing I try to accomplish in this talk is, should I get rid of that? Just to get you guys, since you're all coming at this from different experiences, different interest levels, just to get you guys to think a little bit critically, analytically about some of the challenges when we're talking about global health architecture. Why is this not working? It was working before. There we go. All right. Anybody know who Alan Brandt is? No. Alan's a former colleague of mine. He's a professor emeritus of medical history at Harvard, and really, really terrific scholar, and penned this brief article, perspective piece in 2013 in NEJM, and it, I think, is a nice segue from what Faisal ended on last week about how talking about AIDS really invented the idea of global health. What do we mean by that? Alan just details in a very short piece 3 remarkable sets of convergences. One is, first of all, science, which we should all celebrate. And that was the creation of, the discovery of ARVs, antiretrovirals that actually work, right? Can't treat something if you don't have a medicine or a therapy or a surgical intervention to fix it. Second is money. We're going to spend some time talking about money today. And the third is, and this is where, a lot of us who grew up, matured professionally in this early 2000s, felt like we were at the beginning, the cusp of a new era, and it needed a new name, global health. And grounded in this idealism that I hope some of you, if not most of you, feel, and a sense that we had to be advocates, activists to bring the resources and the knowledge and the skills that we developed in advantage settings like the United States to other places in the world. Money. So before 2003, does anybody know what happened in 2003? Was anybody born before 2003? I'm sure most of you were. I know, that's mean. Anybody heard of PEPFAR? What does PEPFAR stand for? Okay, I'll have you look it up later. PEPFAR was initiated by George Bush, the second, and it was funding for AIDS, basically. And it took basically the US's investment in what we now call global health and understand as global health from, like I said last week, 0 to 100. Less than $1 billion, which is still a lot of money before 2003, less than that before the 2000s, to 5 times that much. And you can see where most of the money went. Most of it went to HIV/AIDS. The Global Fund is malaria, TB, right? And what else? Malaria, TB, and HIV/AIDS. So most of the money was going to effectively work on bringing down the burden of disease or coming up with ways to treat folks with that particular disease. And obviously the biggest burden of that disease was born in the continent of Africa. So that's where most of the money went. We were not alone. Other countries contributed. So you can see the relative share. This was in 2022. That is going to change next year for reasons that I won't, hopefully don't have to explain. But we're not alone. The United States isn't alone in this. And with all this money, anybody know who that is? Who's that? The Chancellor. Our Chancellor. Somebody didn't know that. Dr. Julio Frank, the physician. Anybody know what Dr. Frank, Chancellor Frank, we should call him, did before he was the president of Miami and the dean of the School of Public Health at Harvard? Any guesses? He did. What government? No. Good guess, though. He was the Minister of Health of the country of Mexico. Whoa. Pretty darn cool to have him as our chancellor. Yeah? And he and his colleagues and team created an imperfect but an important first step for the country of Mexico. They enacted universal health care coverage, right? Underfunded for sure, not providing all the services, but pretty remarkable achievement. Yeah? He penned this in 2013, the same year that Alan did when he was the dean of the School of Public Health. And with all the excitement, the attraction, interest in global health, he wanted us to be cautious because there's no governing structure. Long paragraph. I'll read the parts that I think are most relevant, and this is stating the obvious in some ways. Global governance is distinct from national governance in one critical respect. There's no government at the global level. Populations are organized into sovereign nation states, but there's no hierarchical political authority or world government that has jurisdiction over these nation states. Traditional instruments for mobilizing collective action at the national level, such as taxation, law enforcement, democratic decision-making procedures, are mostly absent at the global level. And then if we skip down, oftentimes students are like, well, what about the WHO? The WHO is now governed by 194 states and is charged with organizing international responses to shared challenges. However, there is widespread consensus that the current institutional architecture, now more than 60 years old, is unable to respond effectively to contemporary global health threats. Today, the WHO stands on a crowded stage. Though once seen as the sole authority on global health, the WHO is now surrounded by many diverse actors. Julio and Suri put a nicer looking schematic than I think actually warrants the reality of the architecture of global health, but tried to create buckets or categories of entities that participate in this space. You have the WHO, you have countries, you have multilateral organizations like the World Bank, you have academic institutions like the one we're in right now. You have the media, you have the private sector, you have civil society organizations, which is also known as nonprofits, and you have philanthropies. A list on the left of some big actors back in 2013. Most of them are still around and present. And Julio and Suri identified three challenges for global health governance. Sovereignty. Sovereignty means what? All sorts of murmurs. Sovereignty just speaks to the fact that you're sovereign in your own country, right? But you're not, or your own county or your own city, but you're not sovereign, over another country. Laws are limited to the country that you live in and are a citizen of. Sectoral challenge. What do we mean by that? Do physicians working in this space think the same way economists do? Do economists think about these problems the same way anthropologists do? Do anthropologists think about this the same way as philanthropists do? Most definitely not. So you have a sectoral challenge, right? All these different interests, different ideas, different disciplinary lenses, and no way to decide who gets to speak authoritatively, and no mechanism to bring people together naturally to work together. The last one, accountability. What does that mean? Accountability just simply means, who do you have to answer to, right? In the case of a government, under ideal circumstances, it's the voting population, right? What about a nonprofit? They answer to their board, their funders, in some sense. What about an academic medical institution? A hard one. The community, the board, something like that, some mix, right? What about a philanthropy? Whoever's providing the funds. These are challenges, right? So I often get accused by my peers that I'm too much of a realist and I dampen people's idealism. And I'm okay with that. I think that it's important to be thoughtful and realistic and honest. And we've been at a crossroads for a while, and I'll expound on that a little bit in this talk. And I always go back to my two favorite quotes. This is a different one from Charlie Munger, but it's spot on. If you don't think about incentives, you can't think about systems. People do generally what they're incentivized to do. You're incentivized to study for your exam next week, correct? Right? Because you want to become physicians. Simple as that. You can abstract that basic idea to any discipline, any domain. Same holds true. So those of us who come from this perspective of, and I count myself in this camp, certainly I think most of our faculty and staff count ourselves in this camp, of sort of like the social justice lens, have for years sort of resisted, fought, and said, really, you can't have global health if you're not approaching it from a social justice lens. And I still want to believe that and cling to that, but I also know that descriptively it's not true. And again, I think it's important to just say that for what it is and decide what you want to do about it. I had the opportunity to comment on this article back in 2000. It was written by some German colleagues who were trying to create a global health curriculum there. And I was actually really upset by this diagram when I first saw it, because it basically says social justice is just one way to think about global health, right? And it's equal to these other perspectives. And I thought about it because I try to be reflective and thoughtful. And again, descriptively, this is actually accurate. And it definitely is the case when you step outside of echo chambers like we tend to create for ourselves, that people do approach work from a bunch of different sort of priorities and perspectives. So I just want to walk through, when you think about on-the-ground perspectives of global health work, the architecture, it's worth it just to spend a little bit of time thinking about this. So let's start with security. The leading value, right, the one that's going to be prioritized is protection of your own citizenry health, focusing on your national and economic security, right? Working with other state actors to keep diseases outside of our borders. Anybody think of an example of this? Yeah, please, Nicholas. You bet, not just malaria. I'm less worried about malaria and more worried about dengue. Yeah. There's some terrific modeling showing dengue is on the geographic ascent. It's a terrible disease. So before the current administration, this is what, if you went to USAID, this is what their statement is. The world's premier international development agency and a catalytic actor driving development results, USAID's work advances US national security and economic prosperity, demonstrates American generosity, and promotes a path to recipient self-reliance and resilience. Does that sound like social justice? No. That's okay, you can speak out loud. I agree. I don't think that sounds like social justice. Up until this year, that was the largest funder of global health in the world. Nowhere in that is anything about solidarity or equity, right? It's about advancing the United States' interests. So eyes wide open, right? What is USAID and the US government funded? Mostly we fund NGOs. And mostly we fund NGOs that are US based. There's a list of them, and look at the millions of dollars that these NGOs have gotten. You could work for one of these NGOs. Maybe some of you have. Has anybody heard of any of these NGOs? Probably. Yeah? And I'm not saying they're not doing good work or haven't done good work. What have they been working on? Surprise, surprise, mostly HIV, right? But also family planning, water, nutrition, TB, malaria, maternal, newborn child health. Where have they been working? Mostly in Africa, where the disease burdens are the highest. Look at the number. This is all 2013 data, by the way. Look at where all the NGOs are situated. Lots of them with lots of money, mostly in Africa. Who's worked for a nonprofit? A few of you. What does a nonprofit exist for? Somebody's got to be able to answer this question. Yeah, please, use your microphone.
My understanding is like it serves the people who the nonprofit was created for. So like the one I worked for was mental health, and so like individuals who are unhoused or had other reasons why they could not access care was ones that we like assisted with.
Yeah, great, thank you for that. Nonprofits are mission driven by definition, right? And the mission is typically to fill a gap that society, whether it's because the government or the community or whatever, has chosen not to adequately fill based on the perspective of the nonprofit, correct? It's a simple idea. Government can't fix all of our ills in society. We need nonprofits, we need the civil sector, we need people to volunteer or join nonprofits to fill that gap, right? Make sense? There's nothing wrong with that. It's a good idea, right? Nonprofits have a traditional life cycle. I've been involved in a few. The thing about nonprofits and their business cycles is that they are businesses. There's a famous statement that once you work in a nonprofit long enough, that goes like this: no money, no mission. Right? It's nice to have a mission, but if you don't have any means to do it, you're not getting anything done. And so nonprofits run like businesses, right? And you have to devote a significant amount of your resources to keep generating the income in order to do the work that you really care about and believe in, and that oftentimes is doing something substantial for a community, right? But then you get into this very typical cycle with nonprofits, where that becomes mostly what you're focused on. How do we stay in business, right? Whereas one of the ideas, at least some of us hold in the global health space, is if we're doing our job right, we should work ourselves out of the nonprofit business, right? The time frame may be 50 years or 100 years, right? But the goal should be to do that, right? Encourage through advocacy, through your work, the government, the society, the community, to take this up in a more meaningful way so that we don't have to keep relying on this made-up mechanism. Does that make sense? Nonprofits shouldn't exist in perpetuity. And yet you saw from Faisal last week, there are 27,000 plus nonprofits working in global health. It's a lot. And they're all doing exactly the same, they're not working on the same thing, but they're all working off that same set of challenges from a business mindset. We need money, and we have to keep doing it. And the thing about it, you saw those lists of the very big ones. Once you create something like that, it's very, very hard if you're in a position of leadership to want to take that down because you've created an economy. Does that make sense? Right? You've created a business. People's livelihoods now are dependent on you doing this. Yeah? And so if you declare victory, that means you no longer have a business, right? And people have to go find other work. This is one of the things, for the other reasons, why people are so devastated by what happened this year with USAID, right? All of those nonprofits you see have had to let go of a lot of people, on the order of tens of thousands. Nonprofits don't always do good, right? Even though they're trying to. The intention is good, the mission is clear. In the global health space, something that I have acutely been a participant in and am not proud of, but recognize it's a huge challenge, is when we go to those countries you saw and create opportunities to fill a gap, who do we hire? Anybody want to raise their hand and offer a guess? Yeah, please. Well, we do hire Americans, that is absolutely right. That in and of itself can be a problem, right? So the nonprofit I shared with you last week that I'm a part of and still consult for has pivoted because of some very thoughtful criticism to hiring only people within the countries that we work, or primarily, I would say 90%. But that in and of itself is a problem. Why? Why might it be a problem? Yeah, Nicholas. Poaching is a strong word, but yeah, I would agree. You're taking thoughtful, engaged, motivated people within the country and purposely and intentionally taking them outside of working within the, for example, government sector, right? Internal brain drain is a way of characterizing that, something we have to be very worried about when we're working in this space, right? Taking that energy, that interest, and diverting it. And everyone will naturally go to a nonprofit because what do? We pay better, the working circumstances are better, right? And there's just a lot of benefits to being part of it. So there's just an entire, again, industry that's going along like this that people don't tend to think about when they're thinking about, oh, nonprofits are doing unequivocal good. Here's a controversial take. Maybe not controversial, but I don't want to assume everybody agrees. One of the most well-known, the Red Cross claims its purpose is to prevent and alleviate human suffering wherever it to be found. Yet it does not acknowledge the causes of this suffering or its perpetrators. It operates, as Teju Cole states in The Atlantic, with an expectation that we can talk about sins, but no one must be identified as the sinner. This logical fallacy remains an immense obstacle on the quest for global equity. It is nearly impossible for colonized nations to gain freedom while these groups neglect to recognize the historical context, name the actors that have corrupted colonized nations for centuries, or hold those actors accountable. She continues, by failing to identify a systemic cause for global inequity, INGOs also maintain the white saviorist narrative that black and brown individuals need saving from white ones. Their websites are laden with images of physicians and volunteers from the West assisting people of color without contextualizing this power dynamic. This imbalance is also reflected in their organizational leadership. They are largely led and funded by white male philanthropists and lack representation from people of color for whom they claim to fight. What do you guys think about that? True. Certainly provocative. Yeah. All right, let's move on. Entrepreneurialism. People love entrepreneurialism, particularly in this country. Innovation. I'm going to create the next thing that changes the world. I love this slide. If you guys don't find this slide ironic, I really am out of touch. And I'm not a Gates hater. Yeah, you're going to ask a question. I love it. First.
Who is built? No, I'm just kidding.
It's so good.
No, I keep thinking about this from a few slides back. We're talking about, the integration of the purpose of nonprofits into government structure, in a more firm infrastructure.
Yeah.
It just feels like nonprofits are very self-perpetuating. And the existence of that, like if I was a governor, I'd be like, okay, you're doing it, hands off, less money for us, even though they're kind of investing money. Have you ever seen a nonprofit actually successfully deconstruct themselves and transition into like solid infrastructure, whether it
Pretty
be like in the
rare.
community or government?
In the global health space, the answer is I haven't. It doesn't mean it hasn't happened. It just means I haven't come across it in my, limited experience. It has happened in the education space with limited success, where a nonprofit at a very community, even like town, small little level, has filled a gap in creating new pathways to educate students or new curricula or whatever. And that has been so successful on a very small pilot scale that it's been incorporated into the public school system. Does that make sense? That's an example of how you can, right, successfully complete your mission, right? Just not aware of that in the global health space. Again, it may exist, but I'm not aware of it. If somebody has, please share. Okay. Gates are putting a lot of money. That's not something to scoff at or, feel bad about. A lot of money. And he's about to put 200 billion and spend it all in the next 20 years, if you believe what he says. They do a lot of good. Won't read it. Lots of vaccines have been put in people. They've saved a lot of lives. There's no doubt about that. We need to be clear and happy about that. All right, I am going to show you this video. Because I like to show you guys videos. 3 minutes. Very curious to see what your reaction will be. The anticipation is. Is it showing up? All right. Yeah, we're not going to do this. This is at Davos. You guys know where Davos is? Switzerland. I'd love to go to Davos. Never been invited. Probably never will be. Anybody been invited? That'd be cool. I'd like to be your friend. All right, it's right about here. Okay. Okay. Can you hear this?
I guess my, oh, that was loud. I guess my question is like if the scan shows up abnormal, then where are these women supposed to go or receive treatment?
Doesn't want to do. He doesn't want to do it. He doesn't want to build roads, right? Most of us don't want to build roads. We don't want to fix the problem of supply chains for blood transfusions, right? It's much easier to get people like us who are super smart, motivated, idealistic to work on a problem like creating the device that sounds like it's going to be a game changer, right? And who wouldn't be excited about doing that, right? So I'm not critical of any of that, but let's not fool ourselves into thinking what he just said is actually going to happen. It isn't without somebody taking care of the roads, ambulance supplies, all the things that go into making a healthcare system functional. So I love your observation. Any other observations? Yeah, please.
The other thing I noticed was, I guess, the question that a lot of people have in development of technology and medicines is the economics of it. And him saying how it's just for this population that they're trying to target, there isn't necessarily a financial benefit or no one's going to profit off of it. And so people don't necessarily want to invest the money. And I think it's interesting because he doesn't really have a financial need to make more money at this point. So he can be very focused on it. But as he was saying, is there's other people that need to be able to support all of this work as well. And it's harder to convince people to do that. And it's even in this or like rare diseases in the United States, even that type of stuff. So I think that was interesting.
Yeah, agreed. So two things. One, there has to be a market, right? So this will only work if the government of Uganda or wherever decides that it's going to spend the X amount of money to buy all of these. And they're only going to do that if they think it's actually going to make a difference in changing maternal mortality outcomes, right? And without solving the other hard questions, it's very unlikely that it's actually going to be a winning proposition. So the problem of scalability, which is something people love to talk about in my community, is just very, very complicated, and not enough attention is paid to how hard it is because of things that are very much outside of the expertise of the people creating these innovative things, right? The other thing that is striking about this, please, before I love not to talk. So, yeah.
I just wanted to ask you, like, how you think for maybe teams of early on innovators or thinkers on a global perspective, what would you recommend those teams start to consider in order to envision scalability early on?
You know the answer to this. Where was this device created? Almost certainly.
China?
Seattle. It's not that there haven't been consultants. In fact, I have very good friends, dear friends of mine who I trained actually as fellows in neonatology who worked on this project and who work on this kind of stuff. And they're not thoughtful. It's just very hard to invest the time and energy in effort into making innovations truly locally driven and championed, right? We create constructs that sort of try to address that, but the first and most important step, and this is a theme for anybody who wants to think about global health as we do, as our community does, is to listen to the community that you're interested in helping or serving, right? And understand what is and what isn't realistic. And if it's really ambitious, you need to understand what all the roadblocks that you aren't thinking of that they know because they live there every day can help you to try to think together to solve, right?
Right.
So the answer is you have to put the time and energy with the community. So why was I super inspired by Abe and Ronnie Bong's work? They just stayed there. They got trained at Johns Hopkins and they went back and they have not had a lot of money, but they have listened to their community, and their community said, this is what's possible with whatever you give us, and this is what's not realistic, right? You're not going to get the magic bullet, right? And it's going to be a much longer time frame, but it has a much better chance of actually impacting that community. Does that make sense?
Yes, thank you.
Yeah, please. Jonah.
I thought this was also a good example of leapfrogging technology, where third world countries will get like very advanced technology, but once the funding stops to repair or like replenish these really innovative tools, is the community any better off than before you intervened? Yeah.
Yeah, absolutely. So that's, first of all, absolutely the case. Hey, take a second to introduce partner in crime along with Tracy and Elizabeth, sorry. This is Dr. Catherine Kate Doval. She is very much part of our community. I'll let her introduce herself at the end. But she's a great person and a great resource. The last thing I'll just say about this is that what dollar figure did he put on creating this? And I can't believe that that's actually true, but no, not for the device, sorry. He said it took hundreds of millions of dollars to create this. That is insane. We don't talk about opportunity costs, that's going to come up, but think about what if it really cost $100 million to do that, think about what that could have done otherwise, right? Fetishization of things that are attractive to us. I'm guilty of it. I'm not saying bad, bad, bad. I'm guilty of it, right? We're all prone to it because that's how we're conditioned, right? So just think about it. That's my goal, is just to get you guys to think about it. I've already belabored this. Not everybody loves Kate's. As I said, I'm guilty of it. In my own world, neonatology, I have had so many people, super well-intended, say, I went to this country and babies are dying of hypothermia, and I've come up with this great idea, we can't rely on electricity. Let's create a warmable wrap that can just be heated up and reused over and over again. It is a great idea in isolation, and it does work. My point here in just showing you this is two different things, two different people that came to me for advice, and they didn't listen to me when I said, this is already being done. Why don't you work together? So what you have happening, again, in the innovative space is you have 10, 20, 30 different projects working on the exact same problem, healthcare problem, and refusing to work together because they're not incentivized to work together, right? Your funding comes from this institution, so you have to do it this way. Does everybody know what CPAP is? CPAP for babies saves lots of lives if they have respiratory distress. I know of at least 15 different CPAP models, all basically the same thing with little different deviations, but all created by different institutions and entities because they wanted to do it with their partner in their way. You only need one, right? You don't need 15 different baby warmers. You need one. But we refuse to work together. So when I talk about global health architecture, this is the reality I'm talking about, right? These are the challenges you have to think about. It's not all fun and games. It's hard. We talked a little bit last week about humanitarianism. I showed you two different versions, right? And we just talked about opportunity costs. These are two different studies, one from 15, one from 16, two different modeling studies done in different ways. You don't have to read them. The first study lowballed it and said that the cost of doing medical missions, short-term medical missions like Mercy ships, even though that's not really short-term, but you get the idea, $250 million a year. Another modeling that was a survey of 600 plus participants, $3.7 billion. Again, whether it's 250 or a billion or somewhere in between, think about what that money could be doing for a health system in any of these settings, right? What if we pooled all that money together and said, you know what? I'm not going to take the trip to Malawi to do some surgeries. I'm going to give it to the government to invest in their healthcare system. Which do you think has more chance for success, for lasting change? Which one satisfies your desire to be a hero? Right? So we all have this. I'm not denying that desire, that instinct. It's not a bad thing in and of itself. It's a question of when you operationalize it, what are you trading away? Right? You have to think about that every time you participate in this space. Does that make sense? Okay, almost done. Who likes SpongeBob? At least one person. Gosh. I used to not let my kids watch this because I thought it was devious. Now I love it and watch it with my adult children. He's a funny guy. It's not all good, right? There's a lot of good, there's a lot of good intentions, but it's not all good. And we have to go within with our eyes wide open. And so I'm not the only one saying this. During COVID and out of COVID, when nobody was doing anything internationally, a lot of our colleagues in other countries started to speak up and say, hey, listen to us. These are just 6 small headlines in medical journals that you probably never would read. But there are probably 1,000 with the same titles, some of which have been penned by me or Kate, maybe, at least definitely me, that basically say the same thing. And whether you like the word colonialism or not, it doesn't matter. The point is we need to be critical of the way of what we're doing. And the real criticism of global health today and now is it's just, even though the name has changed, a replication of what's gone on for all the years that Faisal shared with you. New form, new fancy language, maybe a little bit better, a lot more money, but it's still based on huge power dynamics, huge differences in positionality, and interests and agendas being driven by people who are removed from the problem and are least well positioned to actually solve it. Jerry, love this quote. She's actually a global health geographer at University of Edinburgh, but it might rankle some of you. I'll let you read it quietly. So why do I share this with you? It's a tough pill for folks like us to swallow because we want to believe that we're on the right side and we're doing our best earnestly to try to get us to move in the right direction. But it's hard to give up your power, right? It's hard to step back and listen, right? It's hard to be much more sort of a patient with the process when you're incentivized and conditioned to be quick fixes, right? And the results that you need to show the funder have to be delivered in a compressed time frame, not on 5 to 10 year time horizons, right? Does that make sense? I love that she ends on a somber note. All right, I'm going to end with just talking about our medical school and generally academic medicine. I'm not going to spend only a couple minutes. What's the mission of an academic medical center like David Geffen? Generally 3 things, sometimes people put 4. We are a research institution, generating knowledge, discovery. Whether that's 1 or 2 or 3, it's up to you. What else are we? What are we doing right now in this room? In theory, I'm trying to help with your educational program. Whether I'm succeeding or not, you guys can decide. 3, patient care. Yeah, actually caring for patients and delivering healthcare to them in a good way. The last, most, I would say, medical schools say that they have a responsibility to their community in some way, community service, outside of the actual delivery of patient care. Not all medical schools, but most do. So that's what we're charged to do. That's what we're, in theory, good at. And that's what our incentives are. So what this isn't good at, I'm going to skip this because of the time. You guys brought up, somebody asked a question about research, and I didn't have this slide in last year, but I want you guys, I'm going to read this to you. This is from Paul Farmer and Nicole Campos back in 2003. And once upon a time, I did a lot of work in ethics too. And I've shared this with a lot of my friends in the ethics field, and they hate it. They absolutely hate it. Because each disease is treatable with already available therapies, the lack of access to medical care is widely perceived in heavily disease-burdened areas as constituting an ethical and moral dilemma. In settings in which research on these diseases is conducted, but there's little in the way of therapy, there is much talk of first-world diagnostics and third-world therapeutics. To quote a woman who had returned to central Haiti dying of AIDS after years in the city, "We are good enough to study, but not good enough to care for." I'll just stop there. This is the problem, or at least a problem, when we construct research as our primary mechanism, right? To address what we think of as health inequity outcome problems, right? It can risk falling into, right? Treating people where you know there is actually a therapy available as study subjects rather than patients to provide care for. What's the last sentence she says? It's as if poor people were animals, but we won't serve as guinea pigs. You got to take your perspective as one of these patients, and this was, I think, one of Paul's many brilliant insights, is that he always thought about things from the perspective of the patient in front of him, right? I don't deserve to be treated like a guinea pig when I know 1,000 miles away I could get cared for in this exact, without any of this, somebody saying, let me study this problem in you, right? So when you think about global health research, and again, Kate is a terrific resource for thinking about it in a way that I think is responsible and sound and conscientious. Be mindful of this risk, right? Because academic medicine wants you to do research, and they want you to do research in global health, but there's a thoughtful, conscientious, and a responsible way to do it, and there are ways that we should question. Got it? All right, I'm going to stop. Sorry, I always take too long, but I want to give you guys a couple minutes for more questions. Then if Kate, you want to say anything, we've got 5 minutes. Come on, no questions? Oh, yeah?
Have there been any studies that model the amount of investment and the amount of time it would take for more like horizontal educational interventions to actually solve these problems versus just like the ultrasound AI thing that is not sustainable and creates a dependency on philanthropy?
Studies, I'm not aware of. Like studying that, how that would, play out, no. And it's partly because nobody wants to fund that. Well, I don't want to say nobody wants to, but it's hard to get funding for it. The second is the time scale is really long, and a more generic problem with approaching something that you want to study, a medical education or a intervention that's got a 5 to 10 year time frame, is that it's just very difficult to get people who have resources to accept that kind of time frame to deliver the results that you're interested in, I'm interested in, and that is a huge problem for us. I mean, both of us have advocated in a variety of different settings when we have people who are interested in funding our work of forget like 5 to 10 years, give me 2 years, right? Or give me 3 years. But if you tell me 6 months and the outcomes that you're interested in are actually meaningless, I mean, they look good on a, on a spreadsheet, but they're actually not transformative in the way that we'd like them to be, you're just doing the same thing over and over again. So part of our job when we sit in positions of leadership is to push back on would-be funders and say, we won't do this unless you give us, right, a longer time frame. And you don't get to tell us what the measurements are for outcomes that are meaningful. That's going to be sorted out with our partners on the ground. Does that make sense? Go ahead, Kate. Yeah.
Yeah. Can you guys hear me? Yeah. Oh.
I can give
There
you
you
that.
go.
Here.
Yep, now? Okay. I totally agree. I think another piece that makes it really challenging to do is there remains these decades long stereotypes, narratives about what our global partners capacity, integrity looks like. To say, no, we're going to hand over skills, we're going to hand over, there's a lack of trust, right? And that I think is a major barrier to quality global health, particularly in terms of research to practice.
Given the history of intervention from countries like us, where sometimes intervening can make things worse, and structural barriers continue to have create that circumstance for us, how do you prevent people like us who are interested in being effective in the space that is meaningful, in a way that's meaningful, from having paralysis about doing work and being in that space in general?
And I love that you asked it. Thank you. There's a two-part answer. One, we can't control the paralysis part on you, but what we have a responsibility to do, and I think the community of folks that we love to work with and trust, we have a responsibility to situate your experience and your learning in a way that minimizes, right, the unintended or the negative or the harmful consequences that I've touched upon today, and maximizes your opportunity to see this work being done in what we think of as a responsible, conscientious, equity leaning, I won't say equity producing sort of way. And that's actually doable. But again, you have to accept that, again, you're not going to be the primary focus of attention. Your interests aren't going to be the things that are most elevated. You're going to spend a lot of time listening, learning, and respecting the voices of the people that you're going to ostensibly help. And your time frame for measuring what you think is, what we all think or that community thinks of as success, is going to be much longer. So if your goal is to get a paper out of a 6-month experience, that can happen, and that mechanism exists, but that's probably not serving the community that you're interested in interests, right? So does that answer your question? So our responsibility is to create those opportunities for you. And we are the first to admit they're not perfect. None of this is perfect. But if the people that the community that you're a part of is honest and thoughtful about trying to create those and reflecting on them as the process goes on, then I think that's what that's what we're committed to doing. And I feel actually really good about it, because I do think that there's a very strong community of us that are committed to doing it this way.
Thank you. What about outside of the global health program at UCLA, if that makes sense?
Well, that's why I share all of this to you, is because I can't, right? You're all going to graduate from here, and there's nobody that's going to say you can't or can or do this. All we can do is to try to create some conscientiousness in you to think about these things, right? Medical missions, research outfits, innovation hubs, they all are well-funded, and they're all going to continue to exist. You have to decide how you want to participate. That's your decision. All we can do is to try to give you things to think about when you make those decisions. Yeah? Go ahead, Kate.
Bare minimum longitudinal partnerships. Keep going back time and time again. Sit down and have coffee with people over enough time. You'll start hearing real perspectives of is this actually working for you, or are you just trying to make us feel better about ourselves, right? So that bottom line, whether you're here, whether you're completely somewhere else in 10 years, be longitudinal in how you partner.